cities where I did learn that you have to read the reviews for the hotels to realize what part of the town they're in. Because I made a mistake when I first was traveling. I said I thought I needed to get closest to the site. So I was like, I'm going to get really close to the site and just pick a hotel nearby. Sometimes that's a bad choice.
Yeah.
Like in Miami, I think I was in the worst section of town ever. You wouldn't want to be out. I was like, but I've had, once I kind of learned that, you pick a hotel in a nice area. And I'm with you. I always pick a hotel that has breakfast because I don't want to get up in the morning and have to go find breakfast. I'm like, breakfast has to be, on site so that I can get something done while I'm eating. And, but I also did for a little while, I would pick especially I had a Baltimore site and I had to be there a couple of times. So I would look at the baseball schedule and I'm like, here's some days that are good with me. Do any of these work? And,
but no, that's a good strategy though. If you're one of those people that are into sports or what have you, if it's a concert or something going on and schedule around, that's a good strategy.
I was like, if I'm going to travel, I'm going to, try to see something. One time I was in Ohio, I went to find someplace to eat. I'm walking down the road and I kid you not, there was like a sign on something and it says something about $30 hockey tickets. And I'd never heard of their hockey team. And I'm like looking it up on my phone and it was a National Hockey League. I'm like, okay, like $30 hockey tickets. Why not? So you can, I think if you're, like I said, if you're comfortable and confident about traveling on your own, you can make some fun out of it.
Yeah, for sure. And then some of the places are interesting. They're not what I guess some might consider like the traditional fun places, but I find that the ones that aren't the traditional fun places are the best because then you can kind of explore and venture out and find things that you never even thought would be, interesting or fun to you. So yeah, I agree. But I'm going to take your advice. I think the next time I'm going to plan around like a game or something fun, like a play, a show or something.
Yeah.
I like that.
Find out what food they're known for. I do that a lot when I would get to a place and say, okay, tell me what what food is this area known for? Yeah. I ask the coordinators ahead of time sometimes, like, tell me your favorite restaurant in that area.
That's a great tip. A great tip. I'm still in it. Okay. So, you became a CRA, in-house CRA, traveling CRA at Moffitt. Then what next? Where'd you go from Moffitt?
Well, it's kind of a funny thing too, because while I was at Moffitt, I did take a position as an internal auditor because we didn't have any internal research auditors at the time. So I did that for a very short period of time, and kind of set up the program that they're using now to internally do the research audits. Before they were contracting out for all of those. And then, of course, COVID hit and we're all working at home. And I'm surprised as I say this out loud sometimes. Something came up and one of my friends mentioned she wanted to send my resume to somebody. She says, this sounds like a perfect fit for you. And I was like, okay, whatever, here's my resume, didn't make much about it until somebody from Yale called me. And I was like, Yale, as in like Connecticut, and they were like, yeah. So I started interviewing with them. And seriously, I just sat there kind of thinking, this would never have happened if it wasn't for COVID, because I never would have thought of a remote position in another state. But, it came up and here I was interviewing for it. And as I said previously, while I was interviewing for it, I kind of had some reservations, or I had to kind of figure it out if I felt confident doing this. And I called my two best mentors, and really anybody who has a chance to mentor somebody or has a mentor. I just can't speak more highly about that either, because I called them both and, talked about my fears and what I liked about the idea, what I was worried about. And both of them really convinced me to give it a try. And I accepted the position with Yale, and I'm now the assistant director for their monitoring team, their clinical research monitoring team.
Nice.
And it's like I said, it was, definitely something. If somebody told me a couple of years ago that I would be working for a university in Connecticut while I live in Tampa, I would have said, really,
Wow.
So it evolved out of something COVID related. Once everybody was working at home, they realized that they could open up their pool of candidates for different positions by, allowing for remote work.
Right.
And that's how I got to this position, which, so I have to say, I'm laughing that it's been almost 2 years since I wore a pair of shoes to work, but.
That's awesome. That's amazing. And a lot of people don't think about that too. They think that they have to be within the geographical vicinity of the whatever the
Yeah, I never would have thought of applying either. Honestly, it was my friend Tuki she had talked to somebody there, and she says, "Oh, I think this is a good job for you." She had actually interviewed with them, and she felt like it was a fit for me rather than her, and she sent them my resume. I had never thought to apply for a job that was in another state. So This is just completely new.
Wow. And that again goes back to networking and making those connections and those friendships.
Oh
yeah. Because you weren't even aware that the job existed.
Nope. And it really was. It was somebody, a close friend in clinical research that a colleague of mine from Moffitt, who also, she had left Moffitt and she was working at George Washington University at the time. So, I like that about our field too, that I feel like I have met so many wonderful colleagues through different things and through positions at different institutions.
Right. Wow. That's amazing. People reach out, and some of the topics that we bring up, we're familiar with them. Like you said, there's a lot of acronyms. So I tend to forget that all of the listeners are on the same page. And we mentioned IRB several times, but I don't think we explicitly spelled out what IRB is.
And what they do.
So if you don't mind, just take a moment to kind of explain, what is an IRB? What does the acronym stand for? When we were talking about gaining that regulatory experience, like if you could just kind of give a little bit more insight into that.
Well, an IRB is an institutional review board, and all clinical research has to be IRB approved. And a lot of universities and academic centers have their own local IRB that is affiliated with the university to look at their research. And we also now have huge central IRBs that can look at, large clinical trials or anything across the nation pretty much. The two IRBs I worked at were both, one was academic. It was at the University of Vermont, and the other was Orlando Health. And that's, with the Orlando Health system, they had their own, and that's a group of hospitals in Orlando. So a little different. And every IRB, actually, how they perform these reviews of the clinical research can be very different, but it's always going to be on the same, using the same priorities. And that is really about human subject protections. And that's what an IRB was actually originally set up after there were some sad consequences of bad clinical research done in the past, where maybe they weren't getting informed consent, or maybe people were honestly being abused, not realizing they were on a clinical trial, or not, they didn't have any rights. And so we now have ways of preventing these atrocities from the past from happening again. by making sure that any clinical research that has human subject participants, gains IRB approval. And everybody I've ever met who sat on an IRB, there are always committees of, and it's not just clinical researchers. It is, primarily a lot of clinical researchers will be on the committees, a lot of doctors and a lot of administrators in research, but it's also members of your community. So every IRB board has to have some community, involvement, which makes for some very interesting discussions when they're deciding, what type of research benefits people, what is harm. And sometimes we don't, when you're in research, you think of harm for the human participants as just being like, I don't want to give them a drug that could hurt them. But it can be, when you listen to community members talk about it, you realize it's more than that. It can be, how they, how their feelings are, and whether harm can be if if you're not watching out for their confidentiality, even things like that. So, having worked at a couple of IRBs really helped me to focus on the human research protection side of it. And really, you look at every patient medical chart as, it represents somebody. And it's, the humans that we wouldn't have any research if we didn't have the humans who would, agree to volunteer to participate. So it's a really important thing to remember that these IRBs are watching out for their protection, and kind of makes you really aware of that, what we're protecting when we say that.
Right. That's awesome. And so going back into your now Yale position as an assistant director, how would you say that compares to being a monitor, and kind of give some insight into what your, average day, typical day would look like for those interested in, those types of positions and advancing their career in that direction?
Sure. Actually, I still have I have a whole number of studies that I'm responsible for that I'm monitoring myself, because I have a very small team. So when I say how does it compare to monitoring, a lot of it is monitoring, but I'm trying. That's one of the reasons I'm trying to hire more people, so I could do a little more assistant director work and a little less direct monitoring. But I do have a number of studies that I myself monitor, but I'm also really in charge of the team and making sure my team is, educated. They have the qualifications, making sure they have all the tools they need. And, that can be a pretty consistent job in itself, making sure they have access. We all realize that, to be a monitor means, having access to so many different things. It's not just the medical chart, and it isn't just, the IP, and it's, all the right people and the IRBs and, all the forms and E-reg or whatever, that's a lot of it. But also being there, reviewing the reports and creating reports, and being kind of the first person when they have to kick something up, which everybody needs an escalation scenario, right? Like, or something you can lean on, whereas you're dealing with something and you need somebody to kick it up to. And that's a huge part of the position too, being the person they can kick anything up to so that they can get their monitoring done. And I say that to all my employees a lot. I always say, it's okay to be selfish about your time, because I want you to monitor. So pass the things to me that are maybe chewing up your time and that you don't need to be doing, or that are a problem. So a lot of it is being an assistant director is kind of putting out those fires so that the monitors can get their monitoring done. And then, reviewing anything they need reviewed, and making sure, they have access to everything, and assigning their studies, and kind of, I go to a lot of the meetings myself, the study team meetings, before I assign a study to a monitor, because I get like a feel for it, and I get an idea of what it's going to cover, what they're going to need, and who I need. And then it's much easier to say, okay, then this is who's going to be in charge of it. Of course, some of that also is I'm looking at their workload and who has space and time.
Right. So you're doing a little bit of it all then, basically.
Yes.
You're doing everything.
Well, right now we have, like I said, we're trying to build up the team. Once I have a larger team, hopefully I'll have a few less studies, but there are a couple that I probably will keep as my studies anyhow, just because I've kind of started with them and I'll see them through. But it is my goal to have a few less studies so I can, do the other things. But.
Yeah. Wow. And all from you being in Florida and Yale being in Connecticut. That's amazing. Because a lot of people don't think about, they think that they can only do remote from like a larger CRO or like one of the big pharma biotech companies. So that's awesome.
It surprises me every day.
That's awesome. Yeah.
When people ask me what I do, and I'm always kind of like, well, first of all, you probably won't understand what I do. And second of all, when I tell you who I do it for, it's not going to make any sense.
Yeah, that's awesome. That's amazing.
Interesting.
And so what has been one of the challenges? And are you getting this echo? Because I keep hearing the echo. No?
I don't hear it. Sorry.
Okay. Maybe it's just on my end. So hopefully it's like a glitch and it's not a part of the recording. But back to what I was saying. So in terms of you being the, a director now, and you hiring, bringing in people, looking for people, recruiting people, what would you say is one of the biggest challenges with bringing in people? And what would be one of the, I guess, missing pieces that you would encourage those listening or advise to those listening that you would like to see more of, or even less of?
I think, let's see, I think one of my challenges right now is that I can't offer people 100% remote because we will have to show up at sites, especially, not particularly right now. Although, I'm hoping soon, we all hope soon, we'll be able to do a lot more traveling. But a lot of people I've spoken to really are looking just to do remote. They don't want to travel. And that's kind of too bad. A part of me is very invested in remote. I think a lot can be done that remote, that we shouldn't have to travel as much. But there is that little bit that, we have to check up on some of these sites. And IP really is something that's hard to, you can look at reports and justify, what kit number was assigned to this patient. And was it, in this chart here, it says it was this kit number, and in the medical record, it matches. But that's not the same thing as really going on site and going to the pharmacy and doing, a monitoring visit that way, and showing up on site, with like a closeout visit and being able to, really physically, see some of the things, and meeting the teams. The site qualification visits aren't the same if you can't go on site. So I think that's one of the biggest challenges is right now, a lot of people are looking for just remote work. And, I don't have 100% remote work to offer. It's currently remote, but we will have to, go to these sites. And we are reviewing investigator-initiated studies, but again, Yale has a lot of studies that are multi-centered, that we are running a multi-center site study, and the people are going to need to travel, to go see some of the sites in UPenn and Columbia and wherever else we're doing the research. So that whole travel thing and remote, I believe in this day and age, I've seen a lot of things written on LinkedIn where people are like, we can do it all remote. I feel like we can, honestly, but maybe we shouldn't do it all remote. There are some little pieces that we need to show up and be present as monitors. And so that's kind of been the challenge for me, is that so many, and there are a lot of positions out there right now that are just 100% remote. So it's hard for me to convince somebody, come and look at my position. It's not 100% remote, but look at it anyhow. It's a great position.
Yeah.
So that's kind of been the challenge. I think the biggest challenge has been that. And right now there are far more positions open than there are people to apply for them. There's, there is a lot of movement, and that's another challenge. Like, I want to bring somebody in, I want to train them, I want to get them involved, and I don't want to lose them. So that's, once you invest in training somebody, you'd like to be able to offer them, incentives to stay. And that's tough right now in our field, because a lot of people are moving around, and a lot of people are moving around pretty consistently.
Yeah.
So, so those are some challenges out there right now in our field. But I would say also and there's some pluses with that, because you can work from home, most of the time. And that's fantastic. And, I can keep you from being on the highway 2 hours a day if you take a position and, work from home. And, you may have to travel to a site once in a while, but that's not the biggest part of the position. So there's a lot of, I think, pluses. I think remote work has provided us with a lot of certainly comforts that way, where we can work from home. So it's, like I said, it's hard to find people who don't mind traveling. And I know that in the future, we're going to have to do some traveling, and that's, going to be a challenge.
Yeah. And I don't know if you've noticed this, but specifically with oncology, right now, most of the sites, they aren't allowing monitors to come on site unless, of course, it's like a super emergency, or, like you have to really prove to them this is basically the only way that you can get done what you need to, get accomplished.
Yeah.
And I found that they're starting to write and trying to implement policies as to where we don't, they won't allow us to come on site, even going forward past the COVID pandemic, so that they can kind of keep this ongoing. I don't know if you've seen that, but with oncology, it seems like this is like the thing now. This is their way in to prevent us from getting on site. But it's, as you know, it's like you said, even though we can, should we? Especially those sites that are high enrollers that we know are at risk, they have all these deviations. I mean, there has to be some type of line, like maybe we don't need to come every week or every 8 weeks or whatever, but to just say never, I mean, there has to be a line.
I think you're right. And it's going to be figuring that out and using lessons learned. And I hope that some of the lessons we learn aren't like negative lessons, but some of them probably will be, with trials maybe that didn't get to have any on-site monitoring. How good is the data? What were the problems, and what are we, what are we going to see? I hate to see, some trials that were halted during COVID, and you wonder about the data. Is that how good is the data?
Right.
Are they now going to need to enroll more people to get good data? And anytime you have somebody volunteer for a study, you want to be able to tell them that what they did for you, pushed the science forward, or was some help or direct benefit. And, I would hate to think that these patients provided us this data that we can't use. To me, that's just, that would be really sad. So, I hope that I hope the push to not have any on-site monitoring, I hope people are really being cautious when they even think through those things, because I don't think we're at that point where we can say 100% remote monitoring can be viable everywhere. Maybe some places and maybe with some trials, but it would take some really experienced teams. And, and like I said, I really don't know how you do a really great job with IP if you can't walk in and see where they're storing the IP.
Yeah, I agree. And my sites, they'll give you virtual tours or they'll send you images of what's in stock. But of course, all of that is it's it's still kind of like an assumption, right? Because we assume that they're showing us everything that is, you know, that they really have, or everything that's valid, or it takes a lot of assumption, and we don't really get to see like where it's specifically being stored or how it's specifically being stored, because they could just pull it out and put it on the counter. We don't know.
Snap some photos.
Right.
And then, we don't want to believe that, but we do know,
Right. It has happened in the past. So it is, yeah, the industry is definitely shifting, and COVID has definitely caused us to rethink the way that we run things. But for some reason, the oncology studies, they are like very adamant, and no, I get it. The patient population is very fragile.
Right.
Compromised. It's different than maybe a weight loss study or a vaccine or what have you. But there still has to be a better way, because even when we come in and monitor, it's not like we're in the area where the patients are.
Right. And I think that way too. Monitoring doesn't mean we have to be inside the clinic around the subjects. We can be in an admin building, and we can meet with the PI and the coordinator at some other spot. Usually you are not in the clinic with the subjects.
Yeah. Very rarely have I been, maybe one of those smaller type of, private practice cancer facilities.
Right.
But like you said, for the most part, it's in a completely different building. There's no patients. Maybe we could have the PI come over there to do the meeting. But there has to be some type of accommodation, or even if we can meet with the PI remotely, but in terms of us coming on site to monitor, there has to be something, because I've seen a lot of deviations. I've seen a lot of backlogs in terms of data entry, because, a lot of times there's not a push unless they know a monitor is coming.
True.
And, if the visit is remote and all they're going to get is a phone call or email, it's unfortunate that it has to be this way, but it's not as encouraging as the monitor is going to be on site tomorrow. We need to get this done. So there's been all those type of different little things, missing records when it comes to complete SAE files, and even the ISF. A lot of people, maybe they have EMR, but they didn't necessarily have an electronic ISF in place. So it's like they have a flash drive and then they're trying to share the flash drive. And, of course, they don't have everything on the flash drive. For the most part, a lot of them are only capturing what was being, filed from the time of the quarantine going forward. Yeah. So it's like, well, where's the rest of the files? Like, how am I going to get that? And it's just creating a lot of gaps, a lot of holes to where we can be audited. And, you don't want the 483. You don't want sites to be shut down. You don't want fines. You don't, God forbid, you don't want any type of legal consequences. And I think people tend to forget about that.
Yeah. And again, you don't want data that you can't use, which, is
most important,
really a huge loss.
It is. And these patients take a lot of their time. They're risking their lives. They're allowing themselves to be vulnerable, like you said, putting themselves on the line so we can have this data. And you do not want to end up with data that's, not valuable and you can't even use it.
Yeah. That is a concern. And I don't know what the answer will be. I mean, I understand some of these centers saying, well, now that you can do it all remote, you should. But on the other hand, I mean, I don't think it is something that we can say that everything's going to go 100% remote. I don't think it can. But I mean, we're going to have to see. Maybe there will be some concessions in places that don't want to go back to having us in the clinics, but I think you can be on site without being in a clinic. And I think we need to look for those opportunities.
I do too. Yep, absolutely. Absolutely. There has to be some type of accommodation, right?
Right.
If it's not going to allow us, quote unquote, on site, there has to be a way for us to physically be able to meet and get our hands on the data and see what's going on. So
Of course, that means they're going to put us in in a basement on top of some boxes with a chair that's like missing, a wheel. But
yeah, but they do that anyway, right?
Yeah, exactly.
I mean,
I've sat in a hallway of one place. I mean, seriously, in the hallway, trying with my laptop on my lap because that's what they had available. But we'll make it through. And maybe it would be, maybe we need to make concessions for sites that can't, it's too much, maybe a lot of work for them to set up a lot of visits, and we need to just whittle it down and say, okay, as long as you let us come on site, we'll come on site less often or something. Maybe both sides need to kind of come into something and figure that out. But especially, I think another thing hurting our data right now is the turnover, because every place I have talked to in the past, probably 8-10 months, has been short-staffed. Like every team is short-staffed. And then they have turnover, and then the data's late. And data entry is late because the new person, just started and they don't know the study. And I think that's going to affect data too, just as much as us. Maybe that means we need to come on site more, and nobody wants to hear that. But we've got some challenges ahead.
Yeah, COVID has definitely created a lot of new challenges, which is why I always tell people now that this is the best time to get in the industry, because everybody's hiring. There's so many open positions. Like you said, you'll hire somebody, but you can't keep them. They're constantly being poached and going to the next position, which in terms of an employer perspective, it's challenging because, like you said, you invest in training, and it's like you're skeptical because you don't want to invest and you can't even keep the person for 3 months, then you're back to square one. But for the people that are truly interested in growing their careers and getting to that next level, this is the best time because there's so many opportunities out there.
That's true.
And the industry is really growing. It's really expanding. I tend to say it's because of COVID, and it has made everyone so much more aware of the clinical research process in general. Because before it was kind of like this hidden secret society that no one knew about. But it's a great opportunity and a great time to get in the industry. But if people will give these entry-level inexperienced people an opportunity, that's what it boils down to.
It does. And there's some big CROs that are well known for having great training programs. And I think right now, you see a lot on LinkedIn. You see people constantly, posting something that they just took this new position. So I think those big CROs that have those great training programs, this is probably the best time in their industry ever, So that is, it's a great time. I think it's a great time to get into our field. Definitely.
I agree.
I wish I got into it earlier anyhow. I wish in my 20s I had heard of it, but
it's so crazy, right? Because it's been around for a while, but it's like, until you just so happen to run into that one person or that one thing, it's not advertised, which is kind of my goal with starting this platform, so that people in elementary school, they want to be in clinical research. They want to be a CRA because everybody knows, I want to be a doctor. I want to be a lawyer. I want to be a teacher. Those things. I want it to be just as popular as those professions, because you can have such a wonderful career. It's a career. A lot of people, they say they want to help people, right? This is an industry where you can do the same thing. You can have a wonderful, prosperous career, helping people, very lucrative, all the above, but most people just don't know about it.
Right. Oh, I totally agree. And you are definitely a piece of the puzzle that is moving the research that's getting those therapies to the market. And I had somebody ask me, and this is about 3 years ago, and it stuck to me because it kind of was painful. Because somebody asked me, they were like, well, do you really like just pointing out people's errors all the time? And I was like, that's not what I'm doing, But, it's more than that. I mean, we're really helping to clean the data, which is helping to get the data in a manner so that it is valuable, so that it can be used, so that you get, the data to the FDA and you get those therapies onto the market sooner. So it's a really important part of the process, I think, and it's an exciting part. You're helping to move medical research ahead.
Absolutely. And that's just research in general. I feel like people who ask those questions don't understand the research process.
Right.
Right?
Mm-hmm.
Because I mean, that's just in anything in life, period, there has to be some type of calibration where people go back and double check and recheck.
Right.
I mean, that's just, in my opinion, that's how life is.
Right. And you worry about all those industries that don't have people like us. I'm like, wait a minute.
Right? I mean, so yeah. But I can see how a novice or somebody new to the industry might say that, because sometimes it does feel like all you're doing is putting out fires. But hey, that's why we're here. That's what we're here for. That's our job. Like firefighters, that's what they do, right? There's always an area that needs fires put out. So
yeah. And if research data was clean all the time, they wouldn't need us, but it's just not. They do need us.
Right. It's just a crucial component. It's just a necessary part of the process. So like you said, you either enjoy it or you don't, long story short. So, what would you say? I know I've kept you long enough. What would you say would be, and I've heard you mention mentors and how that has been an integral part of your success, and mine too. I always advise people, mentors. Everybody, every successful person I know, whatever scale the success is, they always mention mentors. What would you say would be like the one tip or the top 3 tips that you would leave aspiring CRAs or even the CRAs that are looking to advance their careers and maybe get into a director role such as yourself? What would be the advice that you would leave for these people?
I think you're right. One of the first things I would mention is the mentors, because they've made such a difference in my life, and finding people around you who have the stories to tell about how they got there and about what they've seen in research, because that's how you're going to find out what interests you the most, and kind of which direction to go. One thing I think back to too is I sat down one time, and this is before I moved to Florida, and I kind of was writing out all my skills and trying to update my resume. And I realized, like, we all at a certain point, after you've had some different positions, we have a skill set, but you need to be able to go through your skill set and say, which ones do I like and which ones do I not really want to be doing again? Because for a while, like, I had accounting on my resume, and I was like, it's a skill set of mine, but I don't want to be doing it. It's not like in my interest. So I just like take that off. And I think that's an important thing to tell people, like, go through the skills that you have, line them up with what maybe these different positions use for skill sets, but choose the ones you enjoy the most, because you're going to spend a lot of your time doing them. And for CRAs, everybody who I've ever met who has our position, they like things to be organized. They like to organize things and clean things and make things, fix things and problem solve. So it's definitely an important part of the job, and you have to be kind of detail oriented. You have to be good at organizing your own time and coming up, you track your own studies and you track your own time, and you make sure your reports get out and things like that. So it takes people who are independent, who like organization. They like to kind of fix things for other people, because a lot of it is that you're doing that. And people who kind of like regulations and drawing, helping people draw inside the lines. Because I tell people sometimes that's a lot of our role is, we know the protocol, and it's like handing, sketching a sketch to somebody and saying, I'm going to give you the crayons, I'm going to give you the outline, and I need you to stay inside those lines, and I'm going to come back every 8 weeks to make sure you are, or something, So, you go through your skill set and you decide, does that sound like me? Is that really what I like doing? And I think that'll help you kind of find which way you're going. I really think going through your skill set, figuring out what the skills you really enjoy the most. And again, if you're confident about traveling on your own, whether it's, a lot of travel or a little, I think that's one of those things in monitoring that you have to find yourself really comfortable about doing that, being on your own, traveling on your own. And if you're confident and comfortable with that, this is a good role for you, definitely. I'm trying to think of what other tips that I would have. Enjoy yourself, find a work-life balance. And when I say that, I'm a huge hypocrite because I focus on work all the time. I'm outside of work talking about work. And so I'm still trying to learn that. But it is important because that's what kind of keeps you happy, and life is meant to be happy. So, definitely keep your work-life balance, and reach out. The conferences, again, I think of how much that helped me to meet colleagues and to, you go to sessions at these conferences about research that you're never going to have. We can't cover every, group of research,
right.
But you go to these sessions and you'll find out about things that you may never get a chance to do yourself. And I've found a lot of benefit in that. So go to the conferences and reach out to people, meet people in your field, talk to people in other fields, and see if, what you're looking at is something that you would like to do.
Awesome. Well, thank you so much, Theresa, for sharing with us today. You have definitely given us a lot of helpful information. I've learned a lot of things, so I'm sure other people have as well. And I truly appreciate you taking this time and this, this opportunity to speak with me. I have definitely enjoyed speaking with you.
We'll have to do it again sometime.
Yes.
I've enjoyed it too. Thank you.
Absolutely.
Thank you so much.
Absolutely.